Right now, as you listen to this, your cardiovascular system might actually be taking a brutal, relentless beating.
Yeah, and the scary part is your doctor would probably have absolutely no idea.
Exactly. I mean, you could walk right into a clinic, get a clean bill of health, and then just walk out with invisible damage compounding in your brain, your heart, your kidneys.
Because we're talking about hypertension today, but, not just the vague concept of high blood pressure that we all hear about.
Right. We are looking at the actual scale of this. According to the World Health Organization, there are approximately 1.28 billion adults between the ages of 30 and 79 worldwide walking around with this condition.
Which is, I mean, that's just a staggering reality. It's 1 in 6 people on the planet.
1 in 6. And for you listening, we know you want the concrete facts here. You want the underlying mechanics and the clinical frameworks without all the, unnecessary yapping.
So today we're using a really highly structured set of clinical lecture notes developed by Dr. Asifullah to just cut right through the noise of this global epidemic.
Yeah, we are doing a deep dive into the absolute reality of hypertension, like how it's actually defined, the hidden traps and how we measure it, the physiological chain reactions that cause it, and what happens when the body just stubbornly refuses to respond to treatment.
And, well, if we're going to understand a condition affecting over 1 billion people, the most logical starting point is obviously defining exactly what it is.
Right.
But the thing is, the definition of hypertension isn't some universal truth. It's a moving target.
I found this part incredibly counterintuitive because the exact pressure that gets you diagnosed with a chronic disease literally changes depending on which side of the Atlantic Ocean you're standing on.
It really does. It highlights a massive philosophical divide in modern medicine.
Okay, so let's break this down. If my blood pressure is, say, 135 over 85, and I go to a doctor in New York using the United States guidelines, specifically the ACC-AHA 2017 guidelines, I am officially diagnosed with stage 1 hypertension, right?
Correct. You
Yeah.
get the disease label right then and there.
I get the label. But if I take that exact same reading, 135 over 85, to a clinic in Paris operating under the European Society of Cardiology guidelines from 2023, I merely have high normal blood pressure.
Yeah, you completely avoid the hypertension label in Europe.
But wait, how does that make sense? The disease itself hasn't changed between New York and Paris. If the European guidelines know that cardiovascular risk increases at those lower pressure levels, why do they wait until a reading of 140 over 90 to actually trigger a diagnosis?
Well, are they just okay with a little bit of vascular damage? No, it's not about ignoring the damage.
Okay, so what is it?
It's a debate over the risk-to-benefit ratio of prescribing lifelong medication. I mean, the U.S. guidelines are aggressive.
Right.
They classify 130 to 139 over 80 to 89 as stage 1 because they want to initiate lifestyle changes and potentially drug therapy as early as possible.
As long as the patient has sufficient underlying cardiovascular risk.
Right.
Right. They want to put the fire out while it's still just smoke.
Precisely. But the European guidelines, they're more conservative regarding that initial label. They generally require an office blood pressure of 140 over 90 or higher to define hypertension that actually needs pharmacologic treatment.
So they're weighing the benefits against the downsides.
Exactly. The very real side effects, the costs, the psychological impact of putting a patient on daily medication. Now, once a European doctor does start a patient on medication, they do pursue lower targets.
Right, right.
But that initial trigger to start handing out pills just requires a higher threshold.
It's basically like international speed limits. It's not that 135 over 85 is perfectly safe. It's that experts fiercely disagree on the exact millimeter of mercury, where the benefits of a prescription drug outweigh the downsides.
Yeah, that's a great way to put it.
But man, if the difference between a clean bill of health and a lifelong prescription is just 5 millimeters of mercury, how can we possibly trust a single reading? Like, what if a patient just rushed in from sitting in gridlock traffic to get to their appointment?
You absolutely cannot trust it. And that is a massive pitfall in standard care.
Because it fluctuates so much.
Right. Blood pressure is incredibly dynamic. It changes minute by minute based on stress, physical exertion, even the temperature of the room.
Wow.
That's why standard measurement principles dictate that a diagnosis requires an average of 2 or more readings taken on 2 or more separate occasions.
Right, but the framework we're looking at points out that while office visits are the standard, they aren't the gold standard. The ultimate reference standard is ambulatory blood pressure monitoring, or EBPM.
Yeah, ambulatory monitoring completely removes that artificial, highly stressful environment of a doctor's clinic.
Which makes sense. So how does it actually work?
The patient wears a specialized monitor that takes readings automatically throughout a full 24-hour period. It measures your pressure while you're working, while you're eating, and crucially, while you are sleeping.
Let's talk about the sleeping part, because the diagnostic thresholds for this 24-hour monitor really call my attention.
They're very specific.
Yeah, like a daytime average of 135 over 85 indicates hypertension. But for the nighttime average, the threshold drops significantly.
Down to 120 over 70.
Exactly. If your nighttime average is just 120 over 70 or higher, that's considered hypertension. Why is the clinical framework so fixated on a nighttime average when the person is literally just lying unconscious in bed?
Because sleep is the ultimate baseline test for your cardiovascular
I
system.
agree. How so?
Well, when you're asleep, you are stripped of all environmental stressors. You aren't arguing with your boss, you aren't reacting to emails, your sympathetic nervous system, your fight or flight response should be completely dialed down.
Right, so your blood pressure should naturally experience a significant dip.
Exactly. So if your pressure remains at 120 over 70 while you're completely relaxed in a dark, quiet room,
It means your internal engine is basically fundamentally running hot.
yes. If your vessels can't relax and lower the pressure even during deep sleep, it indicates a profound baseline dysfunction. Your cardiovascular system is never getting a break.
Wow. And this concept of the environment influencing the reading, it leads directly to two of the most dangerous diagnostic illusions in medicine, right? White coat hypertension and masked hypertension.
Right, and they are complete opposites.
White coat hypertension makes intuitive sense to me. You go to the doctor, you see the white coat, you get anxious, and your blood pressure spikes in the office.
Classic reaction.
But your ambulatory monitor shows that when you go back to your normal life, your pressure is perfectly fine. You look sick in the clinic, but you are healthy in reality
But masked hypertension is the exact inverse, and it is far more insidious.
because they look fine in the clinic.
Exactly. Masked hypertension occurs when a patient has a completely normal blood pressure reading while sitting quietly in the doctor's office, but they have elevated blood pressure out in the real world.
Which is terrifying because the clinic might actually be the only quiet, uninterrupted 15 minutes they get all day.
Yeah, the second they step back out into their high-stress job or their chaotic commute, their pressure skyrockets.
And the clinical data highlights a really scary reality about masked hypertension. It isn't just a minor anomaly or some temporary spike. Masked hypertension carries a cardiovascular risk that is practically identical to sustained hypertension.
Think about the mechanics of that for a second. It does not matter if your blood pressure was a perfect 115 over 75 during your annual checkup.
Right.
If your out-of-office stress is causing your pressure to sit at 145 over 95 for the other 14 hours of your waking day, your blood vessels are sustaining the exact same structural damage as someone whose pressure never drops at all.
You're just hiding in plain sight, entirely unprotected.
Unprotected and undiagnosed.
That is deeply unsettling. So, okay, once a doctor actually manages to catch this, hopefully using that 24-hour ambulatory monitor to expose the masked cases, the next clinical hurdle is figuring out the why.
Why is the pressure so high in the first place?
Exactly, and Dr. Asifula's framework divides this into two main buckets, primary and secondary.
Right. Primary hypertension accounts for the vast majority, greater than 90% of all cases.
So almost everyone.
Yeah. And when we say primary, it essentially means the elevated pressure is the primary disease itself. There isn't one single surgically fixable tumor or blocked artery causing it.
It's just a mix of things.
Exactly. It's a complex, systemic culmination of genetics, aging vessels losing their elasticity, and lifestyle factors building up over decades.
But secondary hypertension, which makes up the remaining fraction, is completely different. Secondary means the high blood pressure is merely a symptom of a different hidden disease.
It's a physiological domino effect.
Right. And the sources list several common culprits for this: renal parenchymal disease, obstructive sleep apnea, drug-induced hypertension, Cushing syndrome, coarctation of the aorta, and pheochromocytoma.
The clinical imperative here is that if you can identify and treat that underlying secondary disease, you can often cure the hypertension entirely.
Oh, wow.
Yeah, you aren't just managing symptoms with daily pills anymore, you are actually removing the root cause.
And there's a massive update in the source material regarding these root causes. Because historically, doctors spent a lot of time looking for narrowed arteries in the kidneys.
They did, but modern guidelines now recognize a condition called primary aldosteronism as the most common identifiable secondary cause.
Let's explain the mechanics of this because it's fascinating. It comes down to the adrenal glands, doesn't it?
It does. The adrenal glands, which sit right on top of your kidneys. In primary aldosteronism, these glands essentially go rogue and produce too much of a specific hormone called aldosterone.
And what exactly does aldosterone do to the body's plumbing?
Well, its normal job is to regulate sodium and potassium. But when there is way too much of it, it forces your kidneys to aggressively hold on to sodium and it dumps potassium into your urine.
Okay, and where sodium goes, water follows.
Exactly. So your body retains a massive amount of excess fluid.
It's like hooking a high-powered pump up to a closed loop of pipes. You are forcing way too much fluid volume into a system that hasn't expanded to accommodate it.
Right, and the physical pressure against the pipe walls has nowhere to go but up. You're overfilling the vascular system.
I want to look at another one of those secondary causes you mentioned earlier, pheochromocytoma. It's a rare tumor, usually found in the adrenal glands, that randomly dumps massive amounts of adrenaline into the bloodstream.
Yeah, it's a very dramatic presentation.
And the clinical framework provides this classic memory heuristic for spotting it called the 5 Ps.
Right, so if a patient presents with sudden episodic surges in blood pressure, you look for the 5 Ps. First is pressure, meaning episodic hypertension.
Okay.
Second is pain, typically a sudden severe headache from that rapid vascular expansion. Then perspiration or sudden inappropriate sweating.
Makes sense with an adrenaline dump.
Exactly. Fourth is palpitations, feeling the heart racing out of control. And finally, pallor, a pale appearance to the skin as blood is shunted away from the surface.
But here is where the framework challenges conventional medical education. For decades, medical students were taught the rule of tens for identifying this tumor, right?
Yes, the old rule of tens.
It was this neat little rule saying 10% are malignant, 10% are bilateral, meaning in both glands, 10% are hereditary, and so on. But the current data explicitly states this is now partly outdated.
It is.
How did a golden rule of medicine just become obsolete?
Well, it became obsolete because our technology outpaced our old assumptions, specifically genetic testing.
Oh.
See, before widespread genetic screening, doctors only knew a case was hereditary if they could explicitly trace it through a family tree with obvious symptoms.
They had to see the pattern visually.
Exactly. But as genetic sequencing became standard, we discovered that there are actually much higher frequencies of hereditary and bilateral disease than we ever realized.
So the traditional rule of tens severely underestimated the genetic component.
Right, because we simply couldn't see the invisible genetic markers before.
It's a perfect example of why medical frameworks have to constantly evolve. We can only diagnose what our current tools allow us to see. But let's shift to the absolute worst-case scenario. We've talked about finding the cause, whether it's primary or secondary. What happens when a doctor makes the diagnosis, prescribes the appropriate medication, and the patient's blood pressure simply refuses to budge?
Then you are dealing with resistant hypertension.
And stubborn isn't a medical classification, so let's define the actual parameters. Resistant hypertension is officially defined as blood pressure that remains above the target goal despite the patient taking 3 different classes of antihypertensive drugs.
And crucially, one of those 3 drugs must be a diuretic.
Right. And those 3 drugs must be at maximally tolerated doses, correct?
Yes, you cannot have a patient on 3 very low doses and label them resistant. Alternatively, the definition also covers patients whose blood pressure is technically under control, but it requires 4 or more different drugs simultaneously just to keep it there.
Wow. 4 drugs just to hold the line. And the clinical framework offers a very specific directive for these resisting cases. When a patient meets this criteria, the preferred fourth-line drug to add to the mix, unless there is a specific medical reason they can't take it, is spironolactone.
Which brings our conversation perfectly full circle.
How so?
Spironolactone is an aldosterone antagonist. It explicitly blocks the effects of that sodium-retaining hormone we discussed earlier with primary aldosteronism.
Wait, if spironolactone is such an incredibly effective drug for driving down stubborn blood pressure, why isn't it just the first drug we give everybody? Why hold it back as a fourth-line defense?
Because you don't start with a specialized sniper rifle when a broad approach usually works for the vast majority of people.
Fair point.
For the 90% of people with primary hypertension, standard drugs that relax the blood vessels or reduce overall fluid volume work perfectly fine with fewer side effects.
But the fact that spironolactone is so uniquely effective as a fourth-line agent.
It reveals a hidden physiological truth. It suggests that mild, previously undetected aldosterone excess is actually driving a significant portion of these highly resistant cases.
It completely exposes the hidden mechanism.
Yeah.
But we need to look at the systemic fallout here. If a patient has resistant hypertension, or they have masked hypertension that goes untreated for a decade, what is physically happening to their body?
It's devastating.
The framework lists the major target organ damage, and it goes far beyond just having a bad heart.
Yeah, we often think of blood pressure as a cardiac issue, but it is fundamentally a vascular disease. Wherever blood vessels go, hypertension causes catastrophic mechanical damage.
Which is everywhere.
Exactly. The long-term complications include coronary artery disease, myocardial infarction, heart failure, chronic kidney disease, peripheral arterial disease, and atrial fibrillation.
I want to zoom in on 3 specific complications on that list.
Okay.
Stroke, hypertensive retinopathy, and dementia. Because the data explicitly states that hypertension is the leading modifiable risk factor for stroke worldwide. How does high pressure in the arm translate to dementia in the brain or blindness in the eye? Let's break down the actual mechanics of this damage.
Well, think about the delicate inner lining of a blood vessel. It is not designed to withstand chronic pounding pressure.
Right.
So to protect itself from rupturing under that high pressure, the muscular walls of the blood vessels begin to thicken and harden.
It's like replacing a flexible garden hose with a rigid steel pipe.
Exactly. But as the wall of the vessel thickens inward, the actual space inside the tube, the lumen, gets narrower.
Oh, wow.
Now apply that to the brain. You have these microscopic, fragile vessels delivering oxygen to brain tissue. As they thicken and narrow due to chronic pressure, they literally choke off the blood supply.
So brain cells are slowly starved of oxygen over years.
Yes, which accelerates cognitive decline and vascular dementia.
And what about in the eyes?
The retina relies on incredibly tiny, delicate vessels. The high pressure can cause these vessels to leak fluid or literally burst, creating microhemorrhages on the retina, which leads to progressive vision loss.
And in the brain, if a weakened vessel wall finally gives out under the
The
pressure,
ruptures, causing a hemorrhagic stroke. It is a full-body mechanical assault.
it is terrifying because all of this structural thickening and microbleeding is happening completely silently. You don't feel small vessel disease until the damage is already done.
Which is exactly why precise early diagnosis is so critical.
To map this out practically, I want to look at 2 brilliant physiological breadcrumbs from Dr. Asifula's framework. These are clinical identifiers for spotting those rare secondary causes of hypertension without needing immediate invasive surgery.
These are really excellent examples of diagnostic deduction. The first relates to coarctation of the aorta.
Which is what exactly?
It's a congenital narrowing, or like a pinch, in the main artery carrying blood away from the heart to the rest of the body. The clinical identifier here is an arm-leg systolic blood pressure difference of greater than 20 millimeters of mercury.
So the doctor takes the blood pressure in the patient's arm and then takes it in their leg. And if the arm is significantly higher, more than 20 points higher, they know there's a physical bottleneck.
It's basic fluid dynamics. The narrowing usually occurs just after the arteries that branch off to the arms.
Right.
So the heart pumps, the blood hits that narrowed pinch point, and it creates a massive traffic jam. The pressure builds up incredibly high upstream in the arms, but downstream, past the bottleneck, the blood flow is restricted, resulting in significantly lower pressure in the legs.
That makes perfect sense. The second identifier is equally mechanical, but it involves the kidneys and a specific reaction to medication.
Yeah, this one is fascinating.
The framework states that if a patient's serum creatinine level spikes by more than 30% after they take an ACE inhibitor, it strongly points to renovascular disease.
Let's walk through the mechanics of why a blood pressure drug would cause the kidneys to suddenly fail like that.
Well, renovascular disease means there is a physical narrowing in the main artery supplying blood to the kidney.
Okay.
The kidney senses that restricted blood flow and panics, thinking the whole body's blood pressure is dropping. To keep filtering blood properly despite this weak supply, the kidney relies on a hormone called angiotensin II.
And what does angiotensin II do?
It acts like a clamp on the kidney's exit pipe. By constricting the exit vessel, it forces the internal pressure inside the kidney to build up, ensuring the kidney has enough pressure to push waste products through its filters.
Okay, so the kidney has basically rigged its own internal pressure system just to survive the blockage. But an ACE inhibitor is a drug designed specifically to block angiotensin II.
Precisely. The patient takes the ACE inhibitor, the angiotensin II is blocked, and that clamp on the exit pipe suddenly flies open. and the internal pressure instantly drops to zero.
The pressure plummets, the kidney instantly stops filtering effectively, and waste products like creatinine immediately start building up in the bloodstream.
That is brilliant. The drug causes a controlled, temporary failure that exposes the hidden blockage. It proves the kidney was only surviving by using that hormonal clamp.
It really is physiological detective work at its finest.
So, synthesizing everything we've pulled from this clinical framework today, hypertension is a silent billion-person epidemic where the exact numbers matter immensely, even if the guidelines debate the threshold.
Definitely.
The method of measurement is critical. A single clinic reading is not enough, and the 24-hour ambulatory monitor is the ultimate truth teller. Uncovering the why requires differentiating between primary lifestyle factors and hidden secondary culprits, like a rogue adrenal gland.
Right.
And if left unchecked, the sheer mechanical stress of that pressure fundamentally destroys the architecture of the brain, the heart, and the kidneys.
It is a condition that demands rigorous measurement, a deep understanding of the underlying mechanics, and really relentless follow-up.
Which brings me to a final thought for you to consider. We explored the mechanics of masked hypertension, how you can look perfectly healthy in the calm, isolated environment of a doctor's clinic, but your blood pressure skyrockets the moment you re-enter your daily life.
Yeah, those out-of-office spikes.
And the data is clear. Those out-of-office spikes carry the exact same severe cardiovascular risk as constantly elevated pressure. So if the vast majority of us only ever get our blood pressure checked while sitting quietly in a sterile room once a year, what are those invisible, undocumented stress spikes actually doing to the delicate vessels in your brain and your eyes right now while you're sitting in traffic or agonizing over a deadline, completely unaware of the damage?
So, as we have heard from the discussion, that hypertension is the leading cause of morbidity and mortality worldwide. There is some slight difference between American Heart Association and European Society of Cardiology, but all is agreed upon that whatever the level of hypertension or blood pressure, the treatment is risk stratification, lifestyle modifications, and is directed towards healthier goals. Even in ESC guidelines, it may be a little lenient that 140 or over 90 is the cutoff limit, but in American Heart Association guidelines, the earlier limit is 130 by 80 to 89 millimeter of mercury to be diagnosed as a stage 1 or grade 1 hypertension. There are different stages, stage 1 and 2, and stage 3 or grade 3 additionally as more than or equal to 180 by more than or equal to 110 for the ESC guidelines. Isolated systolic hypertension is only higher systolic blood pressure of more than or equal to 130 millimeter of mercury systolic with lower diastolic less than 80 in ACC and more than or equal to 140 but less than 80 millimeter of mercury, less than 90 millimeter of mercury in the ESC guidelines. Management is extremely important, and measurement is the basis for it. 2 or more readings and ambulatory blood pressure monitoring to eliminate white coat hypertension. Sometimes there is masked hypertension. The person is normotensive in the clinic, but at other places he is having high blood pressure. And it is said that masked hypertension is as dangerous as clinically evident hypertension or white coat hypertension. Essential hypertension or primary hypertension has no identifiable cause with polygenic inheritance and environmental factors acting upon them. But secondary hypertension may occur due to primary hyperaldosteronism with a clue on electrolytes of hypokalemia, and it is the most common cause. So simple blood electrolyte levels or serum electrolyte levels can identify this. Renovascular hypertension is ACE inhibitor intolerant with raising creatinine. Obstructive sleep apnea is also a cause of resistant hypertension with morning headaches And a few chromocytoma can occur as episodic hypertension with diaphoresis and palpitations. There can be coarctation of aorta as a cause with upper limb blood pressure more than or equal to 20 millimeter of mercury higher than the lower limb blood pressure. Cushing syndrome is central obesity, stria, and moon phases may also be a cause of secondary hypertension. Mortality: hypertension is a big killer worldwide, and its major complications are related to retinopathy, cerebrovascular accident, MI, heart failure. It can lead to peripheral arterial disease. It can lead to chronic kidney disease and chronic renal failure. So, hypertension has to be controlled to avoid the occurrence of these complications. Then we will come to our fact check that resistant hypertension is more than or equal to 130 by 80 despite 3 antihypertensives including one diuretic at maximum tolerated doses, and spironolactone is the fourth line agent for the treatment in such a cases. And treatment threshold for ESC is more than 140 or 90 millimeter of mercury diastolic, and for ACCHA 130 by 80 millimeter of mercury is the treatment threshold. However, ESC ensures that the blood pressure with treatment is below 130 by 80 millimeter of mercury. It is paramount important that patients should quit smoking, should have lifestyle modifications and exercise to overcome this global burden of 1.2 billion lives affected with the most common risk factor of stroke globally. We need to reduce salt intake and preserve food intake. And also, measurement in ambulatory blood pressure is strict for diagnosis of these hidden cases for more than 130 by 80 in 24 hours and more than 135 by 85 in daytime average, and in nighttime more than or equal to 120 by 70 as average on ambulatory blood pressure monitoring device for diagnosis of hypertension. Otherwise, clinically more than or equal to 2 readings or more than or equal to 2 equations is sufficient. Patient should be reclining. Hypertension is white coat hypertension, sustained hypertension, and masked hypertension. There are 3 categories, and masked hypertension is as dangerous as any other sustained hypertension or white coat hypertension, which is usually hidden, and it is a new entity that is a phenotype matrix of hypertension. ACCHA have different goals. They may look jumbled up and mixed and twisting, but they are less than 120 by 80 normal for ACCHA, and for ESC optimal is less than 120 by 70, while normal is 120 to 129 by 70 to 79. Above 130 is high normal in ESC, while it is hypertension in AHA. The pharmacological management in ASCCHA is 130 over 80 and with sufficient cardiovascular risk in the patient, and 140 by 90 in ESC guidelines, but lower targets may be plausible in this situation. Even ESC recommends a lower target threshold for optimal treatment of this patient. Why we want to investigate hypertension? We have only 10% causes, but we have come across the data that primary aldosteronism is most common. Renovascular diseases are common, especially in young people when they have creatinine rise of more than 30% with ACE inhibitor, and coarctation of aorta is an easily measurable clinical problem with more than or equal to 20 millimeter of mercury rise in the a difference in the blood pressure between the arms and the legs, and if there is more than 20 millimeter of mercury or equal blood pressure difference, then this is coarctation of aorta. Few chromocytoma may have pressure, pain, perspiration, palpitation, and pallor with pressure as hypertension of spotlight on pheochromocytoma. The rule of 10 has been abandoned and it is no longer characterized as this because many different phenotypes have been identified in this clinical issue. Brain with stroke, ischemia and cognitive decline, coronary heart disease, myocardial infarction, heart failure, and AFib, hypertensive retinopathy and peripheral arterial disease, and chronic renal failure or chronic kidney disease mandate the management of hypertension with thorough measurement and follow-up and addition of the spironolactone as agent in resistant hypertension is recommended for the treatment of resistant hypertension. For resistant hypertension, the definition requires 3 antihypertensives including a diuretic at maximum tolerated doses, and despite that the patient is not at the target levels, then the patient is at danger. Primary aldosteronism is the most common cause. Mass hypertension is really dangerous. Ambulatory blood pressure monitoring may be used for risk stratification as well as diagnosis. Spironolactone is the last choice, and global impact of hypertension is very big, so it needs to be addressed sufficiently. Thank you very much. This is Dr. Asif Ullah from KMU Institute of Medical Sciences, KDA cohort.